I had to reconstruct half his face. A single operation, which took me 22 hours.
The bombs are getting bigger.
The bombs were getting bigger. The anaesthetist said to me, Demetrius, have you done anything that you can't stop? And I said, why? And she said, because his core temperature is going through the roof because of his brain injury. He also had a brain injury.
Getting hot.
And he's getting too hot. And he's going to die if we carry on with the operation.
The surgical repair of a bomb blast victim is one of the most complex fields in all of surgery. Today, we have Mr. Demetrius Evriviades, a reconstructive plastic surgeon who was faced with just such tasks and found new and innovative ways to heal and repair bomb blast victims during the wars in the Middle East. It's a stunning combination of the highest medical training, the highest surgical skill and creativity, combined with our very, very bravest serving men. So here we have Mr. Demetrius Evriviades, my good friend, on the Health Drive. I hope you enjoy it. Quite the palaver, wasn't it? Getting set up. Not the easiest thing to do. But here we are. Welcome to the Health Drive, Dimitri.
Thank you.
Right, I'm going to back up, go for a little drive, and we are going to talk surgery. And when was the first time we got in a car together?
Probably
Was it when you got
September
88?
88.
So I say 88. And was it your Fiesta? Was it my Mini? Because that was a van, wasn't it? My minivan. I
You had a little brown
a Clubman, remember?
mini Clubman
Oh, God, yeah.
minivan. You're right.
Yeah. So Liverpool University.
Yeah.
That's where we meet.
And you didn't have your license, so I had my license, and
Yeah.
we only drove around in your car because I was the nominated
That's right.
driver.
That's right. That's
And
how we did it.
And I could supervise you.
Yes.
I could supervise you as a learning driver.
It's quite clever, really.
I'm not sure strictly you're allowed to do that in the first 3 years.
I think it was hazy in those days. But yeah.
Anyway, nothing bad happened.
So we're back in a van, legally, completely legally back in a van now.
Nice man.
Yeah, it's lovely, isn't it? Absolutely lovely. And so yeah, I really wanted to chat about. Obviously, we train together, but our careers go different directions. And how interesting that is about medicine in general. That we all start by doing medicine, and then 10 years later, we're all doing completely different things.
Well, the nice thing about medicine, of course, is that there's a bit of medicine for all types, all personalities, and there's different niches in medicine to suit everybody, and you find your own way, find what suits.
Yeah, and you went down the surgical route. So you're a consultant plastic surgeon, soon to be leaving to become a professor in Dubai, which is incredible, which is absolutely amazing, I'm incredibly proud of you, of what you've done. Yeah, as long as you're leaving. You're leaving. I've nicked all the stuff from your surgery, and it's in the back sliding around.
Hopefully not breaking.
It'll be fine. So, now you went into the RAF quite early, which I was very envious of because you used to get a bit of payment from the RAF.
Yeah,
when we were students.
I was sponsored,
and that was quite nice, wasn't it? That was quite nice. That extra monies.
Well, it meant I didn't leave with quite as much debt as most people, which was good. But of course, then you're committed to the RAF. So I was committed for 6 years, but then the 6 years turned into 22. So it was a life sentence, so to speak.
Yeah, but so 22 years as an RAF surgeon.
Yes.
I would say thank you for your service.
Oh, that's very American, but yes, thank you.
But it's very much correct. Because you had to face some very challenging times because Britain goes to war on more than one occasion, and then you find yourself as a plastic surgeon dealing with people who've been involved in the most extreme injuries possible, which is bomb blasts. So how would you approach that compared to elective surgeries in this country, even complex surgeries in this country, you don't see bomb blasts every day down on the streets of wherever in the UK.
So broadly, injuries are either what we call penetrating injuries, where something stabbings or shootings or other kinds of penetration of the body, or blunt injuries. So you've been crushed, you've been hit by a car, run over by a car, whatever. And then you have burns as well. And the thing about blast injury, sort of IEDs that we were seeing in Afghanistan and Iraq, is a blast injury is all of those. So you have a blunt injury because you got crushed by the pressure wave. People get burnt from the munitions, and also penetrating injuries from fragments.
So it's all these things.
So it's basically the worst injury you can possibly have in many cases. And the severity was quite literally off the scale, because what had happened in the military in the early 2000s is that the care that had been put in place for our soldiers had been improved to such an extent that people were surviving injuries which even a couple of years before would have killed them without any doubt. And those soldiers were surviving and being resuscitated and transported back to the UK absolutely with their lives on a knife edge. And they were placed with us, and I was at the Royal Centre for Defence Medicine in Birmingham at the Queen Elizabeth Hospital. And we were receiving these casualties, and they were almost, they're critically injured, truly critically injured, to the point where we didn't know at that point, this is about 2009, 2010, we genuinely didn't know what we could do that they could stand with, what operations we could do that wouldn't kill them.
Yeah.
So I knew a lot about reconstructive surgery and how to fix any kind of injury, but what I didn't know was whether the surgery, whether the cure would actually kill the patient. And so we had to tread very, very carefully, and I had lots of sleepless nights. Ironically, more when I was in Birmingham, working in Birmingham at the Royal Centre for Defence Medicine. Here, I had more sleepless nights here than when I was in Afghanistan, where although the surgery was incredibly arduous, there wasn't that uncertainty about what was the right thing to do, because it was very straightforward. They were bleeding, you stopped the bleeding. They were full of contamination, you cleaned the patients up, you gave them lots of blood because they'd lost a lot of blood, and you stabilised them, you wrapped them up, and then you put them on a plane and sent them back to the UK. And that was relatively straightforward thing to do. But back here in Birmingham, a lot of time I simply didn't know whether what I was thinking of doing was the right thing or not.
Well, it's deep and heavy stuff with Dimitri. Let's take a quick break for an ad and come back very shortly with part 2 of Demetrius Evriviades, plastic surgeon. Andre here. Well, thanks for watching The Health Drive, and check out our all-natural supplement range, Optimum Day and Night. Now, thousands of people in the UK, the USA and beyond have been using the Oxford Natural supplements to get better sleep, better energy and better overall well-being. Optimum Day, which I always use, is designed to boost energy, to curb cravings, and to keep your metabolism firing all day. Optimum Night, well, that's different. That helps you to relax, to sleep deeply, and to restore while your body is recharging overnight. Now, they aren't magic pills. They are a science-based way to help you feel your best. We've had such great results. Check out Michael Owen, the England footballer, Robbie Lyle from AFTV, Linda, a PI lawyer, Anita, an immigration lawyer, and Owen from United View. All of them have found better control of their daily habits, better mood, energy, focus. And now it's your turn. So scan the QR code, click the link, and use the code word DRIVE for 70% off your first order. Oxford Natural. No gimmicks, no needles, just results. Let's get to it. really fascinating part, that the improvements in the on-field medicine, whereby they could pack things and stop the bleeding, which they could never do before, suddenly created a new type of patient.
Yes.
Well, literally, yeah, that's what you're saying, isn't
yes,
it?
But plastic surgery has been there before. So after the, just before the Second World War, doctors had realised that what killed people with big burns was the burn shock, the loss of the fluid from the burn, and that was what was killing the patients. So they'd started to resuscitate people with big burns with fluid. And then the Second World War happened, and the Battle of Britain fighter pilots and the bomber pilots who were getting burnt in their aircraft, they were getting their severe burns, and then they were surviving, and they had never previously survived. So there's plastic surgeons in the Second World War, most famously Sir Archibald Mackindoe at East Grinstead. He had the same problem. So they had a new cohort of patients who'd never previously survived their injuries, and now they had to fix them. So it was history repeating itself.
And so you have to think of a new way to deal with these patients. So you don't always, there's no absolute rule book.
No.
At that time.
We were quite literally writing the guidelines as we went along, as we worked out what worked and what didn't. And you start pushing the boundaries, but knowing that if you get it wrong, you'll kill the patient.
Yeah. They're that frail at that point in time.
Yes.
That even small issues can be fatal, can be terrible.
Well, that's right. So I had one patient who I had to reconstruct half his face, and I had a very big, complicated operation planned, and I was going to transplant tissue from his arm and from his tummy into his face, and a bunch of other operations, because he also needed some other his legs and his arms treating. And we had half the operation done, both transplants were ready to go, his neck was open to receive the transplantations, and the anaesthetist said to me, "Demetrius, have you done anything that you can't stop?" And I said, "Why?" And she said, "Because his core temperature is going through the roof, because of his brain injury. He also had a brain injury, and he's getting too hot, and he's going to die if we carry on with the operation." I said, "Well, what do you want to do?" She said, "I want to put him back on the intensive care unit and put him on the blood filter so we can get his temperature down. Can we come back and finish the operation tomorrow?" I said, "Yes, we can." So we left him, and then we did that, and then I brought him back the next day. So he had a 10-hour operation on the first day, and then a 12-hour operation on the second day. So he had a single operation which took me 22 hours, with a tea break, with a night's sleep in between.
Yeah.
And that's the closest I came to killing a patient on table, but totally out of the blue.
How did you maintain focus for that long? For a 10-hour procedure, how do you actually maintain focus?
Well, there's natural breaks in any procedure, and there are parts in any operation where you can run surgically. Yeah. There's parts where you have to walk, and there's parts where you have to crawl. And in general, you know where those are going to be. But you do. It's a team sport, and you're the captain of the team, and so you do send people off to go and get a break. Yeah. Including yourself, you have to not neglect yourself as well. So you marshal your team, and make sure everyone's got a break. So keep things moving, and it's very important to keep things moving because you don't want things to drag on. So at the end of the day, the shorter the operation, the better for the patient.
And so when you have a bomb blast patient and you have operated, when they come round from the operation, they may not know they've been involved in an incident. They might recollect this, but they might be knocked unconscious or whatever, might they? So when you do the ward rounds, when they are awake, and you talk about what's happened for the first time, how do you approach that sort of consultation when it's blinding light here? Because there must be they're waking up to a very new situation, And
well, that was. You have to take it very carefully, because you're quite right. If you're in Afghanistan and you trigger an IED, you wake up on the intensive care unit.
that's your first recollection.
Yeah.
Is in a new country.
Well,
Back home,
back
literally,
home.
somehow, suddenly back home.
A week later,
Yeah.
or maybe later.
Mm.
So,
Yeah, because you go to the ITU afterwards,
correct.
so you'll be there and you're
Correct.
not aware of your surroundings
So
there either.
part of the forward care is that the injured serviceman or woman is intubated on the helicopter.
Wow, okay, incredible.
And in part, and this is part of the reason why they were surviving these injuries,
Yeah.
as we pushed resuscitative care, and the helicopter, the MERT, which is the helicopter that will go and pick them up, had an anaesthetist on board, a very brave anaesthetist,
Yeah.
who would be rescuing these guys and intubating them if necessary on the helicopter before they even got to the hospital.
So what's that ward round like then when the person is? I mean, you might not be there the first time they actually come around. They don't wake up and you're there.
No.
So there's always, but I suppose they want to talk to the surgeon and find out what has been done, what's been lost, what's been salvaged, remedied. How do you approach those consultations, those first meetings?
Well, you have to be very straight with people.
Yeah. Is that the best way in terms of?
I think it's always the best. Always, any doctor knows that you can break bad news without taking away patients' hopes.
Because they're very frail, mentally very frail at that point. Was that how they would normally?
No.
Was it a variety of responses?
Soldiers in general are mentally the opposite of frail.
Yeah.
Very robust.
So was it yeah. So a more stoical approach was than the usual.
Very stoical.
Wow.
Very pragmatic as well. In general. In general. Much more than one might expect. I always thought that the amazing thing to me was how stoical their wives and girlfriends were. It was amazing to watch, to see that.
And so you noticed also that there was an issue with these bomb blast victims, the soldiers there, that they would lose what we think of as being, limbs. We see that all the time, don't we? That's the understood cost. But then you obviously thought more deeply because people were losing other parts of themselves as well, including their genitalia. Was big, and I struggle to imagine the complexity of these surgeries. Remember when we first sewed something up together in med school, like a pig's foot or something? We'd cut it and sew it up, and that was probably the last time we actually stitched together. But you've gone on, and now you're doing these phenomenally complex things. But you've noticed then that obviously they've lost major parts of their body, including genitalia. And how did you first sort of notice that was an issue that maybe hadn't been completely dealt with before?
So in 2010, we saw an increase in the size of the IEDs.
The bombs are getting bigger.
The bombs were getting bigger. And so the standard injury was a high above-knee amputation from the blast. But then as the bombs got bigger, the injuries started getting more severe, and they started to get injuries to their genitalia and between their legs. And some patients lost one or both testes, and we had a number of patients who lost their penises as well. So, and credit to the Ministry of Defence, and that pelvic protection, as soon as we reported this, and this was reported up to the MOD, the development of pelvic protection was very rapid. And so we did see these injuries after year and a half, these injuries pretty much stopped happening because the soldiers were issued with pelvic protection. And but then we had this cohort of soldiers who
in between, they sort of fell between there. So so as the bombs got bigger, the damage got higher and higher, and then.
So we started. I started a clinic specifically to look after these soldiers, and it was Paul Anderson, who's a reconstructive urologist, and me, and we used to run this special clinic for soldiers who had these injuries, and the clinic grew, so we got extra more specialties involved, so a psychologist involved, an endocrinologist, rehabilitation specialists, and a urologist. We had Paul, and it grew, and we also started something that had never been done before because it had never been required, which was an emergency sperm retrieval service. Okay. So if you've lost both your testicles, you actually store sperm in the tubes that carry the testis and any remnants. So when the soldiers were brought in via sleep, we would take out the vas deferens and send it to our lab, and our lab managed to work a way of retrieving sperm and freezing it.
I didn't know that.
And so when these patients woke up, having been rendered infertile in the explosion, we preserved their fertility. So I'm not allowed to know because of the legislation surrounding this. I'm not allowed to know precisely the number of children that we've had born through IVF to these soldiers, but I think it's about 8 or 9. So there was that. So we were very proud of that. And then in terms of reconstruction, some people needed fairly simple things, but some people needed complete penile reconstruction. And I think the case I'm proudest of would be a chap who had lost his penis, and I took a flap of skin. So a flap is a piece of skin with fat from his thigh, but I kept it alive on the blood vessels that go to that piece of skin, and I kept the nerve that goes to the outer thigh attached to the flap, and I transplanted it, rolled it into a sausage, and dug out the nerve that used to go to his penis. I connected it to the nerve that now went to this roll of fat, and put that onto where his penis was. And then left that for 3 months, and then brought him back, split it open, took out the lining of his mouth, not completely, but took a strip of it, grafted it in, left that another 3 months, came back, tubularized, so stitched that lining around into a tube, and then closed it again, and then connected that to your urethra. So meanwhile, the nerve had recovered. So if you touched it with his eyes closed, he'd say, "Yeah," he could feel it. That's my penis, and he could wee through it. He could pee through it. Okay. So he then had a phallus, a penis that felt like his penis, and he could pee through it. And I then sculpted the head of it, shaved his head, took a skin graft from his scalp, grafted it on, and your scalp skin is pink.
Okay.
So the head of his new penis then had the right colour, because it was pink. So it now felt like it looked like it, and he could pee through it. And then we sent him off down to London to a specialist centre, and he had an implant put in, so he could then get an erection. So it took us quite a while to get there, but
and
it was great fun.
And many of these things you're creating in your head.
So that operation was not a standard operation, because the standard operation is to take it from the forearm But the thing about these soldiers is the body armour, in the explosion, the body armour protects their trunk very well in general, but their arms take a big hit. So you couldn't do the standard operation.
Okay.
So I had to work it out.
Yeah.
But plastic surgery is quite a creative specialty. We don't do operations. We analyse problems and apply techniques.
Yeah.
You know, and they say if they give two plastic surgeons the same problem, you'll get two different solutions.
Yeah.
I think that's absolutely true.
Yeah, yeah. It is preserving both the skin with the blood supply, with the nerve supply. It's remarkable what you can graft from one place to another.
Well, yeah. So Sir Harold Gillies, who pretty much invented modern plastic surgery after the First World War, he said that plastic surgery is the battle between beauty and blood supply.
Okay, beauty
and blood supply.
Blood supply.
Yeah, and he was reconstructing faces, so that's what he meant by beauty.
So you can only have what the blood supply will allow. Doesn't matter what you wish for.
Yeah,
it's going to have to be fed constantly, and that's got to be patent, hasn't it?
You've got to keep it alive.
Yeah, absolutely.
So it's not a forgiving medium, if you're a craftsman or an artist. Flesh and blood is not a very forgiving medium. So it has a tendency to just die on you.
Sorry. And so the soldiers, and this must have affected their recovery massively from a psychological perspective, to have lost genitalia, to have it reconstructed. Did you see that the psychological
it makes a huge difference.
benefits of that in terms of how they see the future, how they engage in what is, I'm sure, a very complicated recovery process?
Well, I'll tell you something. I did a penile reconstruction, different one to the last one I talked about, and it was all fine. Final operation, I saw him in 2 weeks, it was all healed up, and then he phoned me at 3.5 weeks in a bit of a panic. He said it split open. So he comes in and the end of it was completely split open. And I said to him, what on earth has happened? It was healed. How did this happen? He said, I was in a nightclub. And I said, why? How? He said, I hit it on a table. I said, how on earth did you hit that on a table? And he looked a bit sheepish and he just said, helicoptering. And I said, what is that? And he says, he was swinging it around.
He felt that confident.
He felt that confident.
He felt that confident in it, that he was happy to show the
it,
world.
He was swinging it around and he caught a table on the end and it split open.
Okay, right.
Fortunately, it healed up and nothing permanent was there.
I call that the high end of stoical.
Yeah.
Down here, isn't it? Just around the village here. So,
luckily, we don't have to do too much of that work anymore.
It's interesting that because I imagine sometimes the Ministry of Defence is not famous for taking the advice of medics too early and then providing the right equipment. But here they seem to notice the issue, introduce something new like a pelvic protector, and that was then a way to minimise that issue happening.
They brought it in very quickly. It was very clever. It was tiered. And the first tier was silk underwear, because silk is an incredibly strong substance. Yeah. And the reason it's incredibly strong, my understanding, is it's a single molecule.
Okay. Yeah, a single thread.
It's a single thread. And so woven, it's very, very strong. So everybody got issued with silk underwear. So to this day, the only set of silk underwear I possess is what I was issued with by the military.
I think I've seen them. Well, what a staggering thing to have done, to have used your skills. I always, I've had a different sort of medical career in that way, but I always marvel at what you've done in terms of the skills, the accuracy, the care, because that's what you're doing. It's the ultimate care when something is gone and you have to create it, and it's not just because it's an easy thing to do. It's a very hard thing to do. It's hours and hours of fastidious work to try and return someone to as close normality as you can that way. And
well, I've always said, if I do my job right, my work disappears.
Yeah.
And now I do mostly faces, and one thing that's really improved my work is portrait sculpture. and it changes the way you look. Changes the way you look at things, and then you realise why something looks right. Makes you actively observe. It's great, but it's really improved my work.
Yeah. Amazing. Thank you so much. Thank you so much for everything you've done, for everything you've taught us there.
Thank you.
And again, we go back a long way, to first meeting back in the 80s, and who would have thought when we first met that you'd be doing that level of phenomenal work? I think it's fantastic, and it was lovely to know you. Well, thank you to Dimitri for that fascinating interview and discussion about bomb blast victim repair. Please keep watching The Health Drive. I hope you're learning things. I'm learning so much from it as well, and look forward to seeing you on the next episode.